Hi, everyone. Welcome to this month's Wellness Wednesday, Understanding Pain Through a Multidimensional Lens. My name is Hannah, and I'm a program assistant for the BC Brain Wellness Program, and I'll be serving as your MC for today's event. We are joined today by two very special guests who will be teaching us a bit about what pain is in psychological, social, and biological dimensions, as well as what may affect our perception of pain. To start us off, Nicole Bailey, a graduate research assistant at ICORD, will be sharing her knowledge on chronic pain, as well as some of her research on the effect of stress on the perception of pain. Then to finish up our event, Dr. Kenneth Craig, director of the BC Pain Research Network, will share his experience on what pain is through a multidimensional lens. Before we get started, I'd first like to acknowledge that the BC Brain Wellness Program at the Center for Brain Health is situated on the traditional, ancestral, and unceded territories of the Musqueam people. As all of you are joining from different places today, I do encourage us all to take a moment to reflect and give thanks to the lands where we are privileged to work, learn, and play from. I would also like to take a moment to thank all of our program donors for supporting the BC Brain Wellness Program. Because of your generosity, we are able to provide these educational events and our online classes. As an entirely donor-funded program, we do rely on your generosity to ensure the continuation and development of our program. So thank you so much for your ongoing support. Without further ado, I'll introduce our first guest, who is Nicole Bailey. Nicole is a graduate research assistant, as I mentioned, at Dr. John Kramer's lab at the International Collaboration on Repair Discoveries, otherwise known as ICORD. She has a Master's of Science in Experimental Medicine and currently works as a pain coach at Pain BC. Nicole was also recently appointed to the board of directors at Pain BC. Nicole has built a career in the study of pain with passion for this topic, stemming from her own lived experience and work experiences in pain research and support services. With that, the floor is all yours, Nicole.
Thank you so much for such a nice introduction. Summarize online. I would also like to gratefully acknowledge that in Vancouver, I work, live, and enjoy the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. It is especially important to acknowledge the Indigenous peoples when talking about pain, as chronic pain disproportionately impacts Indigenous people in Canada, as Dr. Craig will discuss in his presentation. So we'll begin by talking about pain in its simplest form, acute pain. Acute means short-term, typically in response to a painful stimulus. Acute pain is a protective mechanism. It's incredibly important for survival. When I touch fire, it hurts, so I learn not to touch fire again. But pain isn't only important for modifying behavior, but also in healing. When I have a broken arm, the pain tells my body to protect my arm until it can heal. Along that lines, not being able to sense any pain, such as with conditions like congenital insensitivity to pain, is incredibly dangerous and leads to very serious injuries and even early mortality. Pain is detected through the body's nociceptive system. Nociception is a fancy word given in science for the detection of harmful stimulus that result in that feeling of pain. Nociception begins with nociceptors, which are specialized receptors found throughout your skin, muscles, and internal organs. There are different types of nociceptors that respond to various stimulus, such as mechanical stimulus, so painful pressure or squeezing or cutting of the tissue, or extreme thermal stimulus, so very, very hot or very, very cold, as well as some chemical stimulus. So when these receptors are activated by any of these stimulus, they're going to send a signal up a nerve into your spinal cord. This is an electrical signal that's sent up the spinal cord through the brainstem and then to different brain regions. And it's the brain that then decodes these electrical signals into pain. So I do a lot of work with people living with chronic pain, and something that comes up a lot is that doctors have told them that pain is made in your brain. What the doctors mean by this is that it's the brain that assigns a pain label to these signals, and it's not the signals themselves being sent up that are painful. Your brain is full of very similar electrical signals. For example, just a light touch on your arm or my voice that you're hearing now are all transmitted similarly. So it's your brain that receives all this information and decides what is painful. Sometimes, however, people with pain are made to feel that their pain isn't real and that it's all in their head. So before I continue, I want to clarify that just because the signal is assigned as pain in the brain, it doesn't mean that it's all in your head. Pain is very real. There can be real biological signals being sent, even if there's not an injury to the tissue. Okay, so we've talked acute pain is important for survival. The brain detects these signals, says it's painful, sends a response, the body stops the pain. In a perfect scenario, this would be the system, but unfortunately, it doesn't always work like this. Persistent pain can be because of an injury that's not healing, or because of some issue with this pathway that begins without an original injury, such as can happen with chronic headaches or fibromyalgia. With persistent pain, the brain detects a signal, assigns it as painful, and tries to stop. But when the signal persists, I like to think of it like a speaker dial. The brain says stop, but the pain doesn't stop, so it keeps getting louder and louder, making the signal stronger until the brain becomes so sensitized that the pain signal is very, very strong. This can get so extreme that some stimulus that shouldn't be painful, like my shirt touching my skin, can be labeled as painful by the brain. The biological process that's underlying the sensitization is called neuroplasticity. Neuroplasticity is the brain's amazing ability to change and adapt throughout our lives as we learn new behaviors and have new experiences. Explaining neuroplasticity also involves one of my favorite analogies in science. So it can be thought of like a field of deep snow. And now imagine you're trying to learn a musical instrument. At first, when you're trying to learn this instrument, it may feel difficult and your brain may struggle to coordinate your fingers and understand the notes. In our analogy, this would be like walking through the deep field of unbroken snow. Each step is incredibly difficult. However, the next time you pick up the instrument, it's still very hard, but slightly easier. In our analogy, it's like you have your past path you can walk through. And the more you practice, the more this path through the snow gets deeper and the easier it is to play the instrument. With enough time and enough practice, your brain can create these super highways and you can play the instrument with ease. But neuroplasticity isn't just limited to learning new skills. As I alluded to with the previous slide, it often plays a role in the development of pain. So when we have these persistent pain signals, the connections in the brain to pain get stronger and stronger until it's formed a superhighway. In some cases, the pain pathway can become so strong that even just thinking about a past pain can activate these systems in the brain and trigger real pain. And this isn't just an analogy. There are physical connections in the brain that are being made. We're just labeling it the superhighway. The good news is that the brain continues to be adaptable. And just because there's a pain superhighway that was formed, the brain can relearn to label these signals as not painful. So it can be moved away from this pain superhighway. And there's a lot of research to support this. It does take a lot of time, though, and dedicated effort. So if you or anyone you know is struggling with chronic pain, at the end of the presentation, I'll share some resources with Pain BC that can help begin this process of relearning. Okay, so far, we've talked about acute pain, important for survival, based on the nociceptors, and it's your brain that says it's painful. We've talked about persistent pain, pain lasting a period of time. The brain turns up the signal, and we have this neuroplasticity changes. But now we'll move to chronic pain, so pain lasting over 3 months. Chronic pain affects 1 in 5 Canadians and is a leading cause of disability worldwide. Treatment options are limited and novel interventions are urgently needed. Chronic pain is an incredibly complex condition to treat, in part because it's influenced by many, many factors. And this complexity can be visualized with the biopsychosocial model. So previously, pain was thought to be in response to a physical injury. But fortunately, this definition has expanded to also include the psychological and social components of pain. In fact, it's been expanded a bit more, just not officially, to also include cultural and spiritual aspects. So biological would be the nociceptors we talked about, how someone's biology is set up for drug effects. Psychological could be things like attitude, anxiety, coping strategies. Social support, family structure, where the person fits into the social structure. And spiritual and cultural could be faith, the meaning of pain in someone's culture, and cultural beliefs about treatments. So I was first drawn to pain research because I have chronic pain. And when I first came into the research, I thought I would be firmly here on the green circle. In particular, something that really stuck with me was health providers continually told me that I had to stress less. And I found this incredibly frustrating because I had aspirations for school and a career, and I didn't like the idea of being held back. So I became very fixated on wanting to understand the exact biology of why I couldn't stress. However, the longer I stay in the field, the stronger I believe that there is no biology of pain that exists without these other dimensions. So when I discuss my research next, I'll situate us here in the overlap between the biological and a bit of psychological. Starting with the biological side of things, in this illustration, I've pointed out 5 brain regions that are involved in both stress and pain pathways, with these 4 also being involved in the limbic system, which is your emotional processing. Understanding that there's this neurological overlap indicates that powerful and prolonged activation of one of these pathways, such as the stress pathway, can also activate the pain pathways. This provides support for clinical observations that powerful emotional or stressful events can trigger pain flares in people already living with chronic pain, or even trigger the start of pain conditions, such as with migraines, fibromyalgia, or irritable bowel. Similarly, these findings support that populations with chronic pain have higher rates of anxiety and depression. So we know that there's this overlap. Now we can look at the impact of stress on pain. We've talked a bit about how in chronic pain populations, stress often increases pain. However, there's also popular anecdotes of athletes or soldiers who don't notice the intensity of their injury until after a high-stakes game or battle is over. That's the classic fight or flight response people think of, where survival instincts take over and people get out of really extreme situations. So how is it that stress could have this split effect? It's been suggested that perhaps the duration of stress explains the split, with acute pain causing decreased stress and chronic pain causing an increase. This makes sense for survival. For instance, my arm is broken, but there's a bear charging at me. I'm going to want to focus on the bear and not my arm until I can get out of that situation. From the chronic side, chronic pain can be viewed as a chronic stressor. So the condition itself results in chronic stress and increased pain. In order to determine if the duration of stress really does underlie this split impact, I turned to the literature. Because chronic pain adds such a strong layer of complexity, I decided to first focus on acute stress and acute pain in populations without major health conditions. So it's like we're building a house, first starting with the basic foundations before we attempt to add all the complex layers of chronic pain. In this first project I'm going to talk about, we conducted a systematic review, which is a rigorous search of existing literature on this topic. We found 49 studies that looked at acute pain, acute stress, and again, in participants without major health conditions. And as you can see from this figure, even though we're very precise, it is still very mixed. So we had 15 studies showing no impact of stress on pain, 11 showing an increase in pain, 17 showing a decrease, and 6 studies showing both an increase and a decrease in pain, depending on the pain test. So it looks like our neat and tidy definition that the duration of stress underlies this may be part of the story, but not the complete picture. But as we learned with the biopsychosocial model of pain, every individual has personalized factors underlying their biology. So I became interested in looking at the unique responses that individuals have to stress. Which brings us to the next project. So in this study, participants without major health conditions came in for 1 day of testing. When they first came in, I hooked them up to some heart recording so I could monitor their different cardiac measures. After this baseline period, we underwent some pinprick testing. So you can see an image down here. These are specialized pinpricks that we use in our pain neurophysiology lab. Each one is weighted differently. They're not designed to pierce the skin, but they allow us to exert a really precise amount of force on a tiny location. And participants verbally reported their pain from 0 to 100 after the pinpricks. So 0 is no pain, 100 would be the worst possible pain imaginable. After that, I applied capsaicin cream. So here's a photo of the bottle. Capsaicin is the active ingredient in chili peppers, and it binds to your heat pain receptors. So it's why when you eat some very spicy food, it feels hot in your mouth, because it's actually activating the same receptors as if you had touched something hot. So the capsaicin made the skin sensitive, and we also recorded their heart during this period to see if the burning feeling caused any changes in their cardiac response. We repeated the pinpricks, and then participants either went through a stress or a non-stressful task while we recorded their heart. At the end of the task, they reported their stress from 0 to 100 before we repeated the pinpricks and debrief. So essentially we had baseline, stress, then pain again. We had 24 participants split between the control and the stress group. Over here, this is the maximum heart rate over the different periods. In the control group, the max heart rate did not significantly change, but in the stress group, during the stress, it did, showing that our stress did work in this study. We then looked at the biological versus psychological stress. With our biological stress, we have a strong negative correlation. By strong, I mean these are individual data points and they fit closely together along this line. By negative, I mean the line is going down. Here on this bottom axis is sympathetic nervous system index. Sympathetic nervous system is your stress response. So this is a measure of their biological stress that we got from their heart recordings. The higher the number, the more biologically stressed they were. And up here we have pain ratings from 0 to 100. So this correlation is indicating that the more biologically stressed someone was, it was correlated with lower pain. Fascinating, the complete opposite was found with our psychological stress when they reported their stress. So this is a weaker correlation, meaning the data points are more spread out, but it's going in the opposite direction, indicating that the more psychologically stressed, consciously stressed someone was, that was correlated with higher pain. These correlations were not found with the control group, who were not stressed during this time. And it is worth noting that this is a small sample size, so more research is going to need to be done in order to confirm these findings. But right now, our results indicate that the psychological and biological responses to stress are distinct and loosely related. This provides support for pain management, which could reduce psychological aspects of stress, such as with counseling, while encouraging sympathetic nervous system activities, such as with exercise. Some 4 key takeaways so far. We've talked about how acute pain is important for survival, but persistent pain can lead to sensitization. We've talked about the biopsychosocial as well as cultural, spiritual factors of chronic pain. We've discussed the overlap in stress and pain systems, as well as some research on how the biological and psychological stress may impact pain differently. This is a photo of my lab. This is my supervisor in the center, Dr. Kramer, and all my fantastic lab mates. I personally find my research fascinating, but there's a lot of other really incredible work being done by this group on the biological side. And I'm going to showcase a few of my lab mates. This is Jessica Archibald. She just finished her PhD, and she was looking at a pain model within a brain scanner. So she had people go into a MRI scanner and applied pain while they were in there. And she was looking at different neurochemicals in the brain, so different signaling molecules in the brain. And in particular found glutamate, one of the signaling molecules, increased during pain compared to rest. And she found this effect was more significant with the female participants. Because of Jessica's work, a master's student, Cassandra, is continuing the study. She zeroed in on glutamate because of Jess's results and is comparing glutamate levels in different regions of the brain. She found this one, anterior cingulate cortex, to be significantly higher glutamate levels, indicating that there could be more activity related to pain in this region. Emily is another master's student doing completely different work, but also incredible. She's looking at a health data set to see if neuropathic pain can be an early warning sign to multiple sclerosis diagnosis. So there are known warning signs before an MS diagnosis, but currently neuropathic pain is not one of them. I could go on and on. This research is incredible and there's so much being done, but because of time, we'll switch away from research, and I'll just leave you with a couple of resources. So if you or anyone you know is struggling with chronic pain, Pain BC is a non-for-profit here in British Columbia with a mission to enhance the well-being of people living with pain through empowerment, care, education, and innovation. They have a lot of really incredible and completely free support services, such as the Pain Support Line, where people can contact with questions related from finding a GP to home care, medication. They also have a coaching for health program, so you can work with a health coach for 12 weeks to regain function, improve quality of life. They have pain support and wellness groups that meet every 2 weeks to build a sense of community and to learn about pain management. They have free resources for self-guided education on this topic. And they have a gentle movements program with 37 videos recorded, which ties in nicely to my research as well. And that is the end. Thank you so much for your time.
Awesome. Thank you so much for sharing your expertise with us, Nicole. I really liked your analogy of walking through the snow to describe neuroplasticity, and it sounds like your lab is working on some really intriguing research. We do have a couple questions from the audience that we'd love to hear your answer to. The first one being, I assume this is about a pain diagnosis, but it says, how do you prove a pain diagnosis when you constantly find that all your test results don't show anything?
That's an incredibly important question, and one that I hear a lot with people at Pain BC. So part of what makes chronic pain so difficult is it is an invisible condition. Something like cancer has a tumor and an answer, but with chronic pain, there's so many aspects of it that we don't know. And there's no test that proves you have or don't have it. So first, just belief in yourself, in your symptoms, that you know you're struggling, you know you're feeling, and you know it's real. And it can be really hard in our healthcare system where there's a lot of dismissal from healthcare providers. So I would encourage you to find support with Pain BC and see if there's other people that can confirm and validate these experiences you're having. But there are a lot of conditions that are real, like fibromyalgia, migraines that don't have a test that will show. So it's incredibly frustrating to go through all these tests and continually not having answers. So I'm really sorry for this, but keep going and keep believing in yourself. And there are diagnoses that can be done without any confirmed tests. That's why we need a lot more research as well.
Awesome. Thank you so much for that. I do have one more question here, and it was about being a pain coach. It was asking, what does being a pain coach entail? Or do you have an example of something you would do with a pain coach?
Absolutely. I am a pain coach with Pain BC. So I work one-on-one and we have phone calls every week or every 2 weeks, depending on the person. And coaching is really to improve function. So we work on the individual's goals and it's very dependent on the client. So whatever their goals are, we can work through. But very common things we work through is things like exercise. So when you're living with chronic pain, it can be really hard to stay on top of your appointments and motivate yourself to do all the physio and other requirements that you're supposed to do. So we can work with them to increase motivation, create a schedule. If there's fear behind movements, talking about barriers for this fear and how can you reduce it.
Amazing. Thank you so much. That was all the questions that I have for you at the moment. But thank you again, Nicole. We really appreciate having you here and hearing about your knowledge today.
Thank you so much.
Next up, we have Dr. Kenneth Craig. He's currently Professor Emeritus of Psychology at the University of British Columbia and Director of the BC Pain Research Network. He has previously served as President of both the Canadian Pain Society and the Canadian Psychological Association. Dr. Craig has greatly contributed to the understanding of pain and has been recognized for his contributions with many awards, including appointment to an Officer of the Order of Canada and the Distinguished Lifetime Achievement Award from the International Association for the Study of Pain. As such, we are very excited to have Dr. Craig share his knowledge on pain through social and psychological dimensions today. Welcome, Dr. Craig. I'll pass it over to you.
Okay, great. Thank you, Nicole, for, as I was saying, an informative and interesting talk. I will try to build on some of the psychological and social dimensions that you described. With you, I share a concern for the frequency of pain. All of us are subject to everyday pain in the form of bruises, cuts, sprains, and burns and the like. All of us are destined towards acute clinical pain of some type, and a portion of us will suffer from chronic pain in the form of chronic diseases that are established or terminal illnesses. But so many people, perhaps the majority of people with chronic pain, suffer from medically unexplained pain. That's pain that doesn't have an adequate diagnostic or tissue pathology basis to explain it. One of the challenges is that there is inadequate control of pain generally, warranting a concern for understanding and controlling pain, developing new ways of understanding and dealing with pain, both in terms of better assessment strategies and developing better treatment strategies, because so much pain is not treated, or it's inadequately treated, or it's mistreated. As was the case with Nicole, I do operate within the biopsychosocial model of pain. I appreciate Nicole focusing upon the biological mechanisms. My concerns have been more for psychological and social contextual factors in terms of the social context, rather than focusing on cultural and spiritual factors, which Nicole emphasized. My focus has been more on family socialization and intergenerational transmission of patterns of experiencing and expressing pain within the family. I do like to point out that when we look at the biology of pain, attention needs to be focused to more than the sensory mechanisms, but the pain implicates the brain really quite broadly, the prefrontal areas and the emotional regulation areas all interact in a very dynamic manner over time. Let me just begin to zero in more on the psychological mechanisms of pain. Let's focus on psychological or intrapersonal functions to begin with. All of us understand these well. Pain warns of tissue stress or damage. It motivates escape or avoidance, and it teaches us about dangerous situations. In my clinical practice as a psychologist, those were the focuses of much of my attention. So risk factors for severe and particularly distressing pain, I've noted here as excessive emotional reactions, destructive thinking, behavioral maladjustment, in particular avoidance of any risks of the pain experience itself, and deteriorating social relationships. And then there are numerous protective factors that, again, need to be assessed and addressed, particularly in clinical work. And so I would focus on issues of self-efficacy, the ability to control the pain, the pain coping strategies the individual used in people suffering from chronic pain, their readiness to change their ability to move from the sick role to a more healthy approach to understanding pain. And for those people who are slated to experience pain on an ongoing basis, their capacity to accept it and regulate it as best they can. So the interpersonal functions of pain also have been very much of interest to me. Pain is important in the social context as well as for the individual. So when people are in pain, their reactions constitute alarm signals for others that can signify danger to others, warranting careful attention. Similarly, pain reactions can instigate empathy and care, not always. In particular, pain expression is counterproductive in the presence of enemies or competitors, people who are interested in increasing the amount of pain the person might be suffering from. And finally, pain expression plays complex roles in terms of establishing where the individual is in the social environment in which they find themselves. That affects one's position in a social hierarchy. It signifies one's capabilities to contribute to the social well-being of the group. So I'd like to point out that there are important social features to pain. We are exposed to risk of pain in social settings, whether we're talking about the workplace, recreational environment, or the everyday environment. And other people do become involved, implicated in the pain experience and expression through their roles as caregivers, perpetrators, or simple bystanders. Pain is involved, social factors are involved in the experience of pain. Pain is much more than sensation. It implicates both emotions and thoughts, and the thoughts are often learned in social environments, in the social context. Finally, expression of pain evolved to elicit others' reactions. I'm talking about verbal and nonverbal expressions of pain, which have been very much a focus of my attention. One of the things that I've tried to do has been to get the International Association for the Study of Pain, international organization that I highly respect and am loyal to, but I've often objected to the definition of pain that they've used. Their definition as pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. We proposed as an alternative, that's Amanda Williams at the University College London and myself, that pain should be seen as a distressing experience. I'm going to block on that as a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. I've tried to move our thinking away from a heavy focus on pain as a sensory experience to pay more attention to cognitive and social components. I asked in response to some work by Sunny Anand and Amanda Williams that and myself that we've done has revised the pain to acknowledge it as an unpleasant sensory emotional experience associated with or resembling that associated with actual or real tissue damage. I continue to quibble on referring to pain as only unpleasant because I feel this does not acknowledge the agonizing qualities of severe clinical pain. And I try to get them to acknowledge the cognitive and social components, but their resistance to that because of the focus on the sensory dimensions. Thinking about pain reactions, I would like to turn to our focus on facial expression. The literature and clinicians would often say that self-report is the gold standard for assessing pain. My argument is being that if you attach overwhelming importance to self-report and don't pay attention to nonverbal expression, you're at the risk of attending to fool's gold because people can manipulate and control their self-report. Self-report is highly attendant to the immediate social context, so one can up or down one's report of pain. On the other hand, nonverbal expression is more spontaneous and non-reactive to the social context, not wholly so, but less so. So we spent a lot of time focusing upon the facial expression of pain. We've adapted Paul Ekman and Wally Friesen's facial action coding system to establishing the anatomic and objective features of the expression of pain as an alternate mechanism for assessing pain. And it's been a very productive approach because it's been valuable in assessing pain not only in humans, infants, and adults, and even seniors, but we and others have adapted the facial expression of pain, this stereotypic configuration that we've described to assessing pain in quite a range of species. I've noted in the literature use of facial expression to study pain in mice, rats, rabbits, cats, ferrets, cows, horses, foals, donkeys, sheep, pigs, and lambs. So there's quite a range of applications there. The challenges of assessing and managing pain are particularly severe with socially marginalized people. By socially marginalized people, I mean people who are not valued or disrespected by others. When I sat down to list the categories of people who might not enjoy the respect of others, I was surprised at how long my list came to be. Race, ethnicity, socioeconomic status, age, religion, gender, sexual and orientation, intellectual capacity, mental health, substance use and abuse, incarceration, homelessness, or experience of violence and trauma, torture, among other attributes, can lead to this kind of mismanagement and failure to provide care for people suffering from pain. These people are exposed to at least the same sources of pain, injuries, and diseases as the population at large, but there's also pain that's associated with marginalized status that needs to be attended to as a consequence of inadequate care or medical comorbidities. So some of the work that we've done has involved looking at pain in marginalized populations. In community-based focus groups, we've been able to look at pain in Indigenous populations. In Canada, certainly Indigenous people suffer extreme health inequities and disproportionate incidence of pain that's inadequately controlled. This is all linked to historically and ongoing colonization of these peoples. We've looked at pain in the LGBTQ2S community and noted that there are multiple barriers to accessing and receiving health care in these populations. They suffer from a high prevalence of chronic painful conditions, disability, and mental health problems. And we've also been able, through collaboration with the people who are mentioned in the reference I've provided at the bottom of this page, to look at pain in refugees and recent immigrants to Canada, talking about people who have fled or retreated from their home countries. And we find that they're frequently exposed to a high incidence of post-traumatic stress and medical emergencies. So life in ethnic minority communities could mean disparities in the provision of treatment and inadequate decisions and increased pain-related suffering. We've tried to summarize these observations in a couple of papers, and I've generated this image to try to encapsulate some of these observations. But you'll note my references to the social communication model of pain in Canadian psychology in 2009, and in a paper with Thomas Agistaropoulos and others in the Psychological Bulletin in 2011. Those are the observations that I wanted to make.
Great, thank you so much for sharing your expertise on the social and psychological aspects of pain, Dr. Craig. That was great. We do have a few questions for you here. So the first question that we have for you here is, why is pain so much worse when one is trying to fall asleep? And do you have any practical tips for that?
It becomes the focus of one's attention, that one is not engaged in activities, involved with other people. There's nothing else to capture one's attention at that moment in time. And so one can zero in on the discomfort. I certainly empathize with that perspective, having a bit of a sore hip at this stage of the game. And the backup question was, how does one come to grips with that? And I can only suggest the usual coping strategies of distraction, relaxation, trying to focus upon other patterns of thinking as one attempts to retreat into sleep. Fortunately, sleep is a powerful balm. It's wonderful when one can achieve it.
Great, thank you for that. I do have another question for you here. It says, how do those of us with chronic pain get doctors to listen or believe that we're in pain when we do need help? Some diminish a person's pain, and it's hard to be heard.
Well, it's a huge challenge. As somebody pointed out previously, pain is invisible, and there's often no tissue damage or pathology that one can refer to. Persuading clinicians is a huge challenge for people. There's a real problem with dismissal of self-report of pain, and I can only suggest that one continue to persist or even to change the medical consultation you're seeking if you're not getting adequate attention.
Makes sense. Thank you so much. I'm just going to pivot over to Nicole here. I have a question for you. This came up just after discussing your work as a pain coach. They were asking, do you have any success with addressing severe chronic migraine pain?
Migraines are very difficult and very variable too. So depending, like tension type headaches, which occur every day, the longer classical migraines, the auras, there's so many. With migraines, there are quite a lot of lifestyle changes that can help too. Unfortunately, with sleep is one of them. They are quite hard to help with. There's some studies done on different types of vitamin supplements like magnesium. So your healthcare provider could help with that. And with migraines, there are quite a lot of medication that you can take, but even that is hard, as anyone with migraine might know, that there's rescue meds, but you can only take them a limited number. So with things like migraines and other chronic pain, it really is like a lifestyle adaptation, I find. It's not just a magical pill, unfortunately, but really focusing on sleep hygiene, on diet, on exercise, and on continually persisting with trying to find medication or supplement, depending on if you can handle different things. And stress. Sadly, I went into my research wanting stress to not impact pain, but it really does. And trying to manage the stress, and that's very difficult and a lifelong journey.
Amazing, thank you. I'm not sure if this was for a specific speaker, but maybe I'll get Dr. Craig to answer first, and then Nicole, if you want to add anything, feel free. But the question here is, are there specific resources that you could recommend for other healthcare practitioners, i.e. registered massage therapists, physiotherapists, etc., to both increase personal knowledge and find out resources for patients?
I'm a fan of Pain BC and would suggest that one consult that group.
Yeah, I would echo that as well. I can send a link in the group chat for the two programs, Live Plan B Plus and Live Plan B. They're both free and self-guided. So there's different depths that you can go into depending on your interest. And there's definitely, as a healthcare provider, it's great to hear that people are interested in learning more so they can better look after their clients and patients.
Great, thank you so much. It looks like those are all the questions that I have here at the moment. So thank both of you again for your expertise. It was really interesting hearing about everything that you have researched and been a part of throughout your career. Thank you again to everyone for joining us today as well. This is our final educational event of the summer, but we will resume these back in September. So please keep your eye on the website or our newsletters for more information on that in August. But it's been great learning with you all these past few months, and we hope to see you again soon. Thank you.